cellulitis involves skin and soft tissue as well, but most times, unless you are able to get rid of the contact lens which is contaminated, you are not going to have the patient respond. Aminoglycosides, fluoroquinolones, chloramphenicol, trimethoprim, sulfamethoxazole are amongst the commonest agents which are used with very good results. Pasteurella, secondary to multiple cat bites, cat scratch is different to cat bite, and so Pasteurella multicoida can affect children or people who are dealing with pets, even though they are domesticated, and that this will lead to also severe and ghastly infections. Pseudomonas, 3 particular kinds of skin and soft tissue involvement. I think I should mention this because oftentimes these are misdiagnosed. Ecthyma in the neutropenic patients, hot tub folliculitis, and cellulitis following a penetrating injury. This is usually a tennis shoe syndrome in people who are stepping on a nail, and surgical inspection and drainage, particularly if the injury involves bone or joint capsule. This is what it often looks like, and that unless you are able to debride it, you are going to find such infections only fester and become worse. Erysipelothrics, again, people who are fishmongers or bone renderers in people who are dealing with animal tissue, also people who are dealing with the carcasses of other animals. Other conditions like Mycobacterium marinum, like I mentioned, fish food containing the water flea, Daphne, which is contaminated with Mycobacterium. Injuries in swimming pools, rifampicin plus ethambutol remains drug of choice, and some strains of marinum are susceptible to doxycycline or Bactrim. Erysipelas, like I've already mentioned, is something that can be mistaken for cellulitis, but this is a gram-positive bacillus. Vibrio in warm marine waters, skin infections, exposure, after exposure, open wounds contaminated to seawater, hematogenous spread following ingestion of contaminated seafood, usually raw oysters. Okay? And skin involvement is a mild cellulitis leading to necrotizing fasciitis or myositis. Aeromonas, I've already spoken about, marinum also we have discussed, and these are some of the clinical features that will come with the mycobacteria. Anterior segment ulcer of Aeromonas involvement, of course this is not a skin soft tissue, but yeah, it is the eye involvement. This kind of infection can often lead to partial blindness and sometimes to complete blindness if you are not able to make an intervention at the earliest possible time. Mycobacterium marinum, again, ulcerative lesions that may very rapidly involve the bone. We are publishing a patient case of, she's now a PhD scholar, but somebody who got infected by a mycobacteria called LAM, Latin American Mediterranean, LAM. Now this mycobacteria, there are less than 15 patients documented in global literature, and that mycobacterium skin and soft tissue infections can be difficult unless you're thinking about them and taking adequate biopsies and treating accordingly. This girl that I'm talking about with the LAM, she had accidentally injected herself by a petri dish lamp, which is the work she was doing, and that she actually ended up losing 4 of the phalanges because the bone refused to get reabsorbed. So important to know, it's not just a skin and soft tissue infection. It can involve bones and joints and crippling. In that, people will lose digits, fingers, sometimes arms and legs. Myositis because of a number of infections including viruses, also parasites, things like Toxoplasma also, but these are usually in people who are immunocompromised. Coxsackie A and B, which is the reason why you will get the hand, foot and mouth, and things like Legionella. This is somebody with trichinosis, poor ingestion of poorly cooked hog's head, periorbital edema, conjunctivitis, commonly seen with trichinosis. So you need to think about these things before you're able to make a diagnosis. Otherwise, I've encountered such patients referred to me for allergic reactions, conjunctivitis, angioedema, everything except the infection. Yeah. So one significant part of literature that has come up in the last 6 months, 8 months I think, is the Ontario experience. 300 odd patients, 56% had underlying disease, 15% overall mortality, and 29% aged more than 60 years. 80 odd percent people died if they got toxic shock syndrome, and 14% were nosocomial infections, 2 household, and most of them were contact infections. Necrotizing bacterial infections that you can separate on clinical diagnosis. You can have a look at myonecrosis versus cellulitis and necrotizing fasciitis. There will be crepitations in couple of these conditions, but in the remaining it will be variable. There may be abundant gas in anaerobic cellulitis. Muscles may not be involved, skin having little changes, and mortality is anywhere from 5 to about 30%. Okay. Let's have a look at some things that the nomenclature says. Nomenclature is helpful only if it provides classification related to prognosis or treatment. There is no such relationship for necrotizing skin and soft tissue infections. The etiology of any of these infections is diverse. You'll find that there are a number of conditions that may lead to these infections. Making a diagnosis can be a little bit tricky unless you have thought about it, unless you're actually able to see, unless you're actually able to ask for an investigation, you're not going to pick it up. So once you've seen gas on the radiograph, you know that there's only about 7 or 8 organisms that will cause to, leading to this kind of gas on a radiograph. Once you've seen a patient like this clinically in your practice, you will agree that a tense edema needs to be corrected very seriously and very quickly. Once you've seen tense edema, discoloration, you must assume that there is gangrene already started, and that the role of conservative therapy is coming to a secondary aspect now. It is going to be primarily the role of a surgeon. Cellulitis, is this cellulitis? Simply cellulitis? This is the reason why skin soft tissue infections can be a little bit tricky. So you need to make the intervention early. You need to have an aggressive approach to start with, and you need to make a subjective assessment as to where this is heading in the next half an hour's time, 1 hour's time, 2 hours time, because that may be all the time that you have to make a impactful difference in the patient's outcome. There are some hard signs that will come with multiple conditions, but of course, like I mentioned, in a lot of these conditions, it is variable. Best predictors, something that again gets debated. You'll find that 2 years ago, all of these criteria got debated again, but I think that a white cell count which is elevated and a sodium which is low, below 130, 135, is something to be taken seriously. I'm going to skip a couple of these slides because these are a lot of these are data that is being contested right now. Delay in diagnosis increases mortality. That's something which is very well established. Corneous gangrene is a condition that is going to require immediate surgical intervention. Most of it because it is area involving that part of a patient's tissues where there is so little space for any infective organism to have inflammation, that these tissues will almost always go into gangrene, and that they are going to require very aggressive therapy with antibiotics, and they are going to require surgical intervention as well. Antimicrobial therapy, penicillin remains my personal favorite only because it has stood the test of time. One of the reasons I say that is, a lot of the bugs that we say are gas-forming organisms, particularly bacteria, not viruses. But if you say that there is Clostridia, or there is, the non-facultative anaerobes, those ones where you are going to say, I'm going to use a particular kind of antibiotic besides the penicillin, that data, except for 2 or 3 antibiotics like clindamycin, in very high doses for long periods of time. Clindamycin in the dose of 900 milligrams every 6 hours is what is required for this kind of conditions to be coming under control rapidly, quickly. But at that dose, clindamycin has its own problems. It's a very good drug. I'm a huge fan of clindamycin. I'll take 2 minutes, sir. Clindamycin in itself, useful drug, but if you're going to use it for any more than 10 to 14 days, you must prepare for Clostridium difficile. And that once you've got somebody who starts to get diarrhea of Clostridium difficile, you're going to then decide whether I should have used clindamycin in this dose for this duration. So crystalline penicillin still remains, my first choice in such infections. There is a role for drugs like chloramphenicol. There is a role for drugs like bacteriostatic agents orally. There is also a role for something like the high-end antibiotics like daptomycin. But then again, daptomycin is your sledgehammer. You're going to cover some organisms which are probably just sitting there doing nothing, not really causing disease. And then you might also cover those organisms which may be causing disease. So I would say a word of caution about daptomycin. Wonderful drug, but I think we should use it sparingly. There is abundant evidence that the older drugs like crystalline penicillin, chloramphenicol, also drugs like linezolid work very well in these conditions, and that's what should be used. The key to any of the skin and soft tissue infections, those that will be very rapid, very rampant, and affect the patient's organs and tissues very rapidly. There are those that will be slow growing. If you think about things like tuberculosis, Vibrio, Pseudomonas, then you're going to make a diagnosis sooner. and that you're going to need to involve your surgical colleagues sooner rather than later. So I'm going to stop here. I'm going to thank Dr. Rajesh Mishra again for a very kind invitation, and thank you all for a very patient.
Because many a time when we get patient when they are already in multi-organ dysfunction, and many a time the diagnosis is missed. Skin and soft tissue infection is probably taken, skin infection. Okay, it will get. It is taken the lightest way probably, although infection look. So we need to tell the people what is the sign when they should get alert. Okay, this is skin and tissue infection is not really simple, and this patient might going to die in next 24 hours, particularly when they are developing myofascial necrosis. So how they should alert themselves?
One part of your question is answered in one part in some of the slides where you have signs of tense edema, gangrene, patient becoming unwell, patient becoming confused, hyponatremia, leukocytosis. These are some of the things that should alert you. But ultimately, we are clinicians. It's going to be a clinical diagnosis. A patient who's got gangrene or impending gangrene or already got compartment syndrome is going to be very sick and very toxic. And if you do the basics of clinical medicine, which is to spend time, few minutes at the patient's bedside, the patient will give you the diagnosis. You don't have to ask questions. You don't have to, go to the detail of being a rocket scientist. You will know because the way the patient is answering your questions or the way the clinical examination is panning out, you will know that there is something really wrong, and this kind of patient needs to be hospitalized and treated aggressively. And like I said, you need to have your surgical colleagues to be involved at an early stage. The presence of a tense tissue in a situation where there is a predilection either as a result of disease, that means your patient is a diabetic or peripheral vascular disease, or somebody who's got an oncology issue, or somebody who's got immunocompromised for other reasons, or somebody who's got a particular profession, somebody who might be dealing with fish or animals or a butcher or some such profession. In those situations where you should think that this skin and soft tissue infection is not simply a cellulitis, because if you do that, then that golden time of an hour or 2 hours is where you're going to miss the diagnosis.
Thank you, sir.
Thank you.
May I invite Dr. Atin Mehta, sir, for his talk. He's going to talk about is preventing sepsis is cost effective or it should not be done due to cost.